Okay, so we end up last time in this medial view of the skull and looking at the different characteristics that you can see as the fossas, which is this the anterior, this will be the middle cranial fossa, and this will be the posterior cranial fossa. And in this bone that we have here, which is the frontal bone, we have a sinus. The frontal sinus. This is the second largest sinus that we have, which are, if you remember, sinuses are open spaces within bones around the nose area that allows for air to be present in there, that helps to lighten the skull and also to to humidify the air. And now, within the sphenoid, we have also another sinus, which is the sphenoidal sinus. And this is located just internally in the body of the sphenoid. Now, the largest sinuses that we have them here in the maxilla, and they cannot be seen in here because this is a medial view, but they will be located around this area. Now, something else that you can see, it is this internal acoustic meatus, which is the internal part of the auditory canal. So outside, we have the external acoustic meatus, and as it's continuing inside, it runs into the cranial cavity, and that in that space is going to be called the internal acoustic meatus. And here we have the bony nasal septum. So the bony nasal septum is made by two bones, the ethmoid, the perpendicular plate above, and below will be the vomer. And then you can see as well the hard palate made by the palating process of the maxilla and the palating bone. And then here is the anterior nasal spine, the nasal bones. Of course, this is the frontal, this is the parietal, this is the temporal bone, and all of these will be the occipital bone. Then you can see here the internal view of the mandible with the mylohyoid line, and then here the submandibular fossa, the angle, the body, the symphysis, alveolar processes, both in the maxilla and in the mandible. So those are things that you can see in this medial view. Internal view, you can see again the fossas, anterior cranial fossa made by the frontal bone, the lesser wings of the sphenoid, and then here we have the middle cranial fossa made by the greater wings of the sphenoid, which will be this, and the temporal bone, which will be this part. And then posterior cranial fossa made mainly by the occipital bone, partly by the temporal bone. Features from the anterior cranial fossa. Well, this little extension that goes up vertically, that is called the crista galli or Cook's comb. This is part of the ethmoid. So in this part of the ethmoid, the dura mater connects. What is the dura mater? Well, it is a membrane that covers and protects our brain. It's the most external membrane, the thicker membrane that protects our brain. So in this crista galli, that's where this dura mater connects. And then on the sides of the crista galli, we have the cribriform plate. So in the cranial plate, we have little holes. Through there, the axons of the olfactory nerve passes. Olfactory nerve is cranial nerve number 1. And I wrote it down with Arabic numeral, but it's actually written with Roman numerals. The olfactory nerve helps us to smell. So that's cranial nerve number 1. We have 12 cranial nerves. So those are features then of the anterior cranial fossa. Now in the middle cranial fossa, we have the optic canal. So cranial nerve number 2 passes in the optic canal, which is part of the sphenoid. Cranial nerve number 2 allows us to see. So you will start learning those names of the cranial nerves and where they are located, where do they pass through, and what do they do. We have one nose, cranial nerve number 1, and we have 2 eyes, cranial nerve number 2. That is going to come into play when we learn all the cranial nerves, because there is a mnemonic to learn it. And then you have the sella turcica, or Turkish saddle. Where the pituitary gland is located, the Turkish saddle, sella turcica, there is actually an indentation that is called hypophyseal fossa. And the other name for the pituitary gland is hypophysis gland. So it's a part of the brain. And then we have the greater wings, and then you have foramen rotundum, ovale, and spinosum. And then foramen magnum on the posterior cranial fossa. So foramen magnum is where the spinal cord is located. That's why it's large. And then on the sides of the foramen magnum, you have the hypoglossal canal through which cranial nerve number 12 passes, the one that allows us to move our tongue. Sometimes people may have a stroke and they can damage the hypoglossal nerve, the nucleus of the hypoglossal nerve, And the person tried to speak, but the words doesn't come as clear because they cannot move their tongue as easily. That's one of the consequences of those strokes. Then we have the internal acoustic meatus, part of the temporal. So now let's look at the orbit, nasal cavity, and paranasal sinuses. So the orbit, as I told you before, is formed by 7 bones, tiny bones, like frontal, maxillary, which are large, part of the orbit, zygomatic as well, but the rest, sphenoid, ethmoid, lacrimal, and palatine, forms a tiny portion of the orbit. And they help to protect the eye and anchor the eye muscles. I think I went through this before. That's why I kind of remember it. But anyway, so then because we have these tiny bones, most of them, since they're tiny, when they break, when they fracture in an injury to the orbit, they're very hard to repair. So then you can have severe consequences, including paralysis of eye muscles if you have damage to these nerves that provide movement to the eye muscles, like cranial nerve number 3, which is called oculomotor. And that's a clinical feature of the orbit. Now, for the nasal cavity, again, it's made by the perpendicular plate of the ethmoid, the vomer, and then you have the nasal bones here, which are bilateral, and then palatine, which forms the floor of our nasal cavity, and then you have the sphenoid that encloses the posterior region of the nose, and then you have the maxillary bones that also forms the floor of the nasal cavity. In general, all these bones help to make our nose to be a cavity itself, just like as the orbit bones helps to form the socket. And then it helps to condition the nasal cavity to allow the inhalation of the air. And then paranasal sinuses, again, they are air-filled cavities in the following bones: frontal, maxillary, sphenoid, and ethmoid. And that's the functions of these, or those are the functions of these paranasal sinuses. So here is the view of the different cavities then that we have in the cephalic area. So here is the oral cavity made by maxillary, palatine bone, and the maxilla. So this is the mouth, basically. And then here we have the nasal cavity made by maxilla, palatine bones, the ethmoid in here. This is the perpendicular plate of the ethmoid. This is the cruciform plate. This is the vomer. And then what else do we have in this cavity? What bones? We have the superior, middle, and inferior nasal conchae. And then for the orbit, we have all of these 7 bones that we talk about, the ethmoid, the sphenoid, etc. And then here we have the cranial cavity itself, made by all the skull bones that we discussed before. And here are the ethmoidal cells. Now, the ethmoid, this is the anterior view of the ethmoid, or the frontal view. It has lateral masses here that has internally these ethmoidal cells. And then this is the maxillary sinus, the largest sinuses. And in here we will have, above the supraciliary arch of the frontal, which will be located in here, we're supposed to have the frontal sinuses, the second largest. Clinical point for the maxillary sinuses. So the floor of the maxillary sinuses is very thin. And the second superior molar the roots of the second superior molar or teeth, it is in close contact with the floor of the maxillary sinuses. So sometimes if someone has infection of this sinus, it can mimic a toothache. And sometimes infections in the roots of these maxillary sinuses can go and traverse this floor of the maxillary sinuses and can seed bacteria into the sinuses, creating sinus infections. And it's a complication. Okay? So here is then the view of the lateral area of the nasal cavity. So here we have superior nasal concha, middle nasal concha, and then inferior nasal concha. Underneath these conchas, we have spaces that are called meatuses. This is the superior meatus, middle meatus, and inferior meatus. Our tears drain from the nasolacrimal canal, from the eyes, into the inferior meatus in the nose. So when we cry a lot, we stop our nose out of flooding the tears into this area. And then again, here we have nasal bones. This is the lacrimal bone in here, and this is the maxilla, forming the lateral part of our nasal cavity. And then this is the sphenoid with the pterygoid plates in here, and this is the palatine bone, and this is the maxilla, forming the floor of the nasal cavity. And just posterior to this nasal cavity, here we have the body of the sphenoid, and this is the sphenoidal sinus. Now, this opening of the nasal cavity posterior is called the choana. It's not the same as concha. And here we have the opening of our nose, basically anteriorly. So we're supposed here to have the hyaline cartilage that makes our nares, this part that is mobile. And then this is the sella turcica of the sphenoid. So we have the pituitary gland in here. When the pituitary gland enlarges, you will have more than likely a little tumor, usually it's benign, that's called adenoma. And that is going to compress the optic nerve that runs in here, cranial nerve number 2. So we're looking in this area in the school, guys. So it's a magnification of this area. Now, this adenoma not only is going to compress this cranial nerve number 2, but also anything that increases the volume of our cranial cavity is going to create signs and symptoms like vomiting, headache, and discomfort. So then doctors have to perform a surgery to remove that tumor. In this case of the adenoma in here. Now think about it this way. Do you think it's easier to perform a surgery like breaking maybe the frontal bone in here or the parietal bone to reach into this area? Or, and then you have the brain lobes in between to interfere with the surgery? Or do you think it will be easier to perform a surgery through the nose, break this part of the body of the sphenoid, and then go through the sinus and then reach the pituitary gland? Which is much easier? Go through the nose to reach this pituitary gland, or go through here? Go through the nose. I see you doing this. And again, this is one of the things that, and this is a common tumor. It's a common way to have a tumor in the brain. So then this is one of the kind of inexplicable things that you're like, why the pituitary gland is there? Well, it's for a reason. Because it's the one that sometimes gives more trouble, and then you can easily penetrate this body of the sphenoid and reach and perform the surgery. I mean, chances are, like if you start the wrong way, like through this or through any way that you want except through here, that you will damage something in the brain. Is that in the textbook? Not at all. Sounds cocky, narcissistic, whatever, but I teach more than what it is in the textbook. And yes, I have a narcissistic personality. I know that. Anyway, so this is then a more anterior view of these markings around the nasal cavity. So this is the nasal septum, the bony nasal septum, and these are the conchi, superior, middle, inferior with the meatuses. And then here we have the frontal sinuses, the maxillary sinuses in here. And kind of a shadow view or phantom view of these sinuses, showing you that these are the second largest, these are the largest, and then the sphenoidal sinus will be here, and then these are the ethmoidal cells. Now, when it comes to the fetal skull, we have the bones forming through intramembranous ossification, as we saw before. And these bones start fusing at different ages, like the occipital, parietal, frontal. So all the bones are the same. And these areas where you're going to have ossification, where we have still these intramembranous, or this membrane, so this is going to be a soft spot. This is the anterior fontanelle, is the largest. Then here we have posteriorly, the posterior fontanelle, that it is not as large as the anterior fontanelle. So this one is the one that closes the last. This is one of the ones that closes the earliest. And then here we have the sphenoidal fontanelle, and this is the mastoid fontanelle. So the mastoid is between the temporal, occipital, and parietal, while the sphenoidal is between the frontal, parietal, and zygomatic. And this is a photo anterior view of these fontanelles in the fetal skull. So anterior fontanelle closes between 18 to 24 months. Posterior fontanelles at 2 months of age. Sphenoidal at 3 months of age. And then mastoid 6 to 18 months after birth. So then the first one to close is this. The second one that closes is this, the sphenoidal, and then this is the third one to close, and then this is the last, the fourth one to close. Why we have those fontanelles? Well, the first 2 years of age, that's when our brain is still forming a lot of neurons, so it grows in size. Without these fontanelles, the brain won't grow. So you have to have room for expansion. And then once the brain stops growing, then it closes. So that's why this one, the anterior fontanelle, closes between 18 to 24 months. So that's a physical growth. However, with the exception of me, of course, for obvious reasons, but each of you here, you still have a lot of physiological connection between your neurons. This is plasticity. You're learning. Your brain still is in development. And of course, as we age, we still learn things and all that, but yours is more critical. You're still doing a bunch of connections. That's up to age 27, 30. So that's physiological matter in there. Now for the vertebral column, we have 33 vertebrae, individual vertebrae. Sorry, not individual. We have 33 vertebrae, and they will be located at different regions, these vertebrae. The ones that are located in the neck are called cervical. The ones that are located in the thorax will be thoracic, in the lumbar area will be lumbar, and just below the lumbar we have the sacral and coccygeal vertebrae. And we have 7 cervical, 12 thoracic, 5 lumbar, 5 sacral. The sacral ones are fused into a single bone that we call the sacrum. And then the coccygeal will be between 4 to 5 fused vertebrae. And that's the ending, the inferior ending of our spinal column. Now, clinically speaking, we identify these vertebrae by abbreviating the first, the vertebrate name with the first letter in capitals of the region. So we have then for cervical, we have C1 through C7. And then thoracic will be T1 through T12. Lumbars will be L1 through L5. Sacral will be S1 through S5, no matter if it's a fused bone. And coccygeal will be, since it starts with C as cervical, will be CO. So it will be CO, and typically it's just one, that you count it as one. So this is in the neck, cervical. This will be thoracic, lumbar, sacral, and coccygeal. And it's 3 to 5 fused vertebrae. So functions of the vertebral column to support the head and the trunk, allow mobility, protecting the spinal cord, of course, and provide attachment to the ribs and muscles of posture. Naturally, we have curvatures. We have 4, 2 that are concave and 2 that are convex. And we are talking about the ones that are concave will be this way, facing posteriorly. The ones that are convex are facing posteriorly as well, with the curvature of a concavity like that. So in our neck we have a concave curvature and also in our lumbar area. And then in our thoracic area we have convexity, and same for the sacral area. For the vertebrae that are separated, which will be cervical, thoracic, and lumbar, we have intervertebral disc in between, that if you remember, we have fibrocartilage in these vertebral discs. And then function of this fibrocartilage is to cushion and allow flexibility. This is part of the axial skeleton. Not because we have there the spinal cord and it is important, just like as the brain is important as part of the nervous system, that doesn't mean that we have to have tubular bone not being able to be flexible to allow us to do this movement. We can still do flexion, extension, lateral rotation with our vertebrae. If we didn't have that flexibility between the vertebrae, we would be like very rigid, and then to catch an object, or to turn to the sides, like if someone talks to you and then you want to turn away. Well, instead of doing this, you'll be like, oh, from your back, right? Oh, it's calling me. So you don't do that. We have several vertebrae there to have some flexibility. So then why do we want to know about the cervical vertebrae? Well, to understand body support, movement, and nervous system protection. So this is the lateral view of the vertebrae and anterior view of the vertebrae. In the lateral view, you can see this curvature. So this is cervical, lumbar, which are concave, and this thoracic and sacral, which would be convex. 7 cervical vertebrae, 12 thoracic, 5 lumbars, 5 sacral, 3 to 5 coccygeal. And in all the ones that are separated from lumbar from cervical up to thoracic, we have these intervertebral discs. We have within the vertebral column, 1, 2, 3, 3 that has specific characteristics, and they have specific names, but the rest, they have the same parts. And you can classify them regionally based on differences, no matter that they are looking like the rest, having the same parts. So this is the superior view of the typical vertebrae. This is anterior, this is posterior, and this will be lateral to the side. So in the anterior part of your typical vertebrae, you have a mass portion of bone that we call the body. So this is like the most prominent part of the typical vertebrae, the body. And then posterior to the body, surrounding the spinal cord, which is this, we have the vertebral arch. And the vertebral arch is made by a tiny portion that is called the pedicle, that is close to the body, and a thicker part that it is located posteriorly, that is called the lamina. Now, in between the lamina and the pedicle, we have processes that goes like this, laterally. So these will be the transverse processes. And then in between the two laminas, we have a process that goes posteriorly and in an angle most of the time. This is the spinous process. The spinous process is actually what we can feel in our back. And that it is used to count the vertebrae for either withdrawing a sample of cerebrospinal fluid or for put a saddle block. Now, this is the top view, the superior view. We also have other processes that you can see in the lateral view, like this one, or the angle view. This is the superior process. And this is the inferior process. And these are articular processes. So the superior process, articular process of one vertebrae, the one below, articulates with the inferior process, articular process of the one above, forming a joint. And with this joint, then we can flex and extend. So since this is the angle view, this is anterior, this is posterior, this is lateral, right lateral in this case. So this is the body, spinous processes that goes posteriorly and into an angle. And these are the transverse processes. And this is the superior articular process, inferior articular process, superior articular process, inferior, superior, inferior. And in between the bodies, we have the intervertebral discs. And this space, which is called the infravertebral notch, that together with the infra-adjacent vertebrae, basically the vertebrae below, they form the intervertebral foramen that allows the exit of the spinal nerve roots. Now, here, in between the body and the arch, you have another foramen. This is the vertebral foramen. This is where you protect your spinal cord. So this vertebral foramen is not the same as the intervertebral foramen. Vertebral foramen will be located between the body and the vertebral arch, while the intervertebral foramen will be between the infravertebral notch and the adjacent vertebrae below. This is a superior view to show you a vertebrae with this intervertebral disc. This intervertebral disc has concentric layers of collagen fibers that are very strong. This is called annulus fibrosus. Annulus means ring. Fibrosus means fiber. So it's a ring of fibers, of collagen fibers. Protecting this fibrous ring, in the middle, this soft tissue that is called the nucleus pulposus. As we age, we start losing water, and this tissue becomes very fragile. And it will be the tissue actually that is close to this area, to the pedicle. So you have then a rupture of this annulus fibrosus, and then the nucleus pulposus exits, and that compresses the spinal nerves. This is called a herniated disc. The herniated disc that ruptures the most are the cervical ones and the lumbar ones. And then depending on what nerve compresses is the consequences. So you can have pain here in the arm and numbness in the arm, or also here in the thigh. So function of this intervertebral disc to cushion the vertebrae, allow flexibility, and absorb shock. Then one of the reasons why, as we age, we shorten in length, in height, it is because we start losing water. And our intervertebral disc, instead of being plump like this, they become shrunk, and then start becoming smaller or shorter. Okay, so now for the vertebrae, the characteristics of vertebrae according to region. So we have here cervical in the left, thoracic in the middle, and then lumbar in the right. When it comes to the body, look at the body of each of these, the cervical, the thoracic, and the lumbar. Which vertebrae has the smallest body? Cervical, thoracic, or lumbar? Cervical. Which one has the largest body? Lumbar. There is a reason for that. The body is where we actually carry the weight of our body. Since the cervical only carries the weight of our head, the body doesn't have to be as big. But then, since the lumbar has to carry the weight of the head, the thorax, then it has to have a larger body. Okay, so that's why. Now, look at the vertebral foramen. Which one is round? From cervical, from thoracic, or from lumbar? Thoracic has a round vertebral body. Did you have a question? No? Okay. I saw you raise your hand. I thought you had a question. So then, this one has a round vertebral foramen. Now, it's not easily seen, but for the transverse process, which is this, and this, which one has holes in this transverse process? The cervical, the thoracic, or the lumbar? The cervical. Well, there is a reason for that. In the cervical vertebrae, we have this canal, this transverse foramina, that's the name, that allows the passage of the vertebral arteries that are going to go and provide blood supply to the posterior area of our brain. So this is the only vertebrae that has transverse foramina. And now the spinous processes in the cervical is not shown in here, but usually is bifid or split, and it's short. And here they don't show it really well, but this one has typically the longest spinous process, and the spinous process, they face in an angle. So that's why we don't see it, because it's more in an angle than the rest. And then the transverse process and the spinous process of the lumbar are short, and they end in a blunt end, while this one ends in a pointed end. So those are the different characteristics. Now, something else that you can see in the cervical is that it has almost a triangular cervical, vertebral foramen, and this one has almost flattened. The reason for this is because the spinal cord in the cervical area, it's a little bit wider, and then in here it starts to be tapered. So it starts ending. So that's why you don't need as much space for the vertebral foramen. Whether in here you need it more, and then in here you have it always round. The diameter of the spinal cord is not as thick as in the cervical area. So here is a summary of the characteristics of the cervical vertebrae. Has transverse foramina, and we're now going to talk about specific details of the two cervical vertebrae, which are C1 and C2. C1 is known as Atlas, like the Greek mythology character Atlas, and then C2 is known as Axis. Axis because it forms a pivot, and Atlas because that Greek mythology character used to hold the world in his shoulders. There's an album from Van Halen, I don't remember which, it's a 80s rock band, and they have in the album cover a guy that is like in his knees, very bulky, holding the world. That's Atlas. Okay, and now, since our head is our world, C1, which is holding the head, it is called the Atlas, C1. Now, C1 is the only vertebrae in our body that it doesn't have a body. Instead of a body, it has masses, lateral masses. So the body splits into half and then forms the lateral masses. And it has two arches. It has the anterior arch and the posterior arch. The anterior arch is shorter, the posterior arch is much, much larger. And then in the lateral masses, the Atlas has concavities that actually fit the convexities of the occipital condyles. So if this was an occipital condyle, and this was one of the lateral masses, the superior facet of the masses from the Atlas, then this convexity of the occipital condyle fits into this concavity, a structure function. Convexity fitting into a concavity. And then because of this, we can rock the condyle of the occipital bone over the lateral masses of the Atlas. And what we can do with that? We can do this. We cannot. So I will be doing this. Okay? So this is the Atlas then. These are the lateral masses. This is the superior articular facet that articulates with the occipital condyles. This is the transverse process with the transverse foramina. This is the anterior arch. This is the posterior arch. This is the anterior tubercle of the anterior arch. This is the posterior tubercle from the posterior arch. And this is the vertebral foramen. And now, here in this internal portion of this anterior arch, we have a facet for articulation with C1. Sorry, with C2, which is the axis. So then, this is the axis, or C2. Axis, as any other vertebrate, has a body. And in the superior portion of the body, which is this, it has a little projection that is called odontoid process. Odontoid, or dens. So the odontoid process forms a pivot and articulates. If this was the vertebral foramen of the atlas, the dens fits into here in the facet for the dens in the anterior arch. So they form the atlantoaxial joint. The articulation between C1 and the occipital bone is known as atlanto-occipital joint. And the articulation or the connection between C1 and C2 is atlantoaxial joint. That atlantoaxial joint allows the dens to gyrate almost, or to kind of have like a little rotation over the facet for the dens of the atlas. This is the atlas, this is the axis, so it does this. The atlantoaxial joint does this. You're looking at a superior view or inferior view. So then, because of that, we can do this. We can do lateral rotation. We can say no with the atlantoaxial joint. So then here we have this superior articular facet from the axis that articulates with the inferior articular processes that are below here of the atlas. And these dens can break during falls, that someone can hit their head, or during whiplash accidents that are severe. And these dens can fall into the vertebral foramen, damage the spinal cord, and the person, if it's lucky, will die. But if not, it becomes quadriplegic, like Christopher Reeve, that according to me is the handsomest Superman actor that has ever existed. He was very athletic, very handsome, tall, you name it. He was riding a horse, he fell down, hit his head, broke the axis, the odontoid process, fell into his spinal cord and became quadriplegic. Couldn't move from neck down. It was sad. Okay? So that can happen. And then the rest, it has like the body, the bifid spinous process, the transverse foramina, the transverse process, the arch with the pedicle, the lamina, and the superior and inferior articular processes. So that's the cervical vertebrae. Now thoracic, we have the medium-sized body, round vertebral foramen, transverse processes, spinous processes, superior and inferior articular processes, and then the infravertebral notch. Now, what is characteristic of this vertebrae? Well, these are the only vertebrae that will have facets for articulation with the ribs because it's only in this thoracic area where we have ribs. And these are called costal facets. So we have here in the transverse process that transverse costal facet, and then in the body we have superior costal facet and inferior costal facet. So that in the body, the head of the ribs, or the costae, articulates in there, and in the transverse process, the tubercle of the ribs articulate in there. And then again, the spinous process of these thoracic vertebrae are long, and they end in a pointed area, and they are in an angle going downwards. For the lumbar vertebrae has the largest body, most massive body, very thick. It has deep inferior vertebral notches. The reason for this is because the spinal nerves, guys, they are larger depending on the area of the body where they are located. If they are located in the neck or in the arm area, like in the cervical area, it's because we have to move our arms, so we have to have thicker nerves than the ones in the thoracic area. So that's why the infravertebral notch is much prominent in the cervical area. Now in the lumbar area, because our nerves has to provide function to our legs or into our thighs or lower limbs, and these are the largest part of our body, then the nerves have to be much thicker. So then we need more pronounced infravertebral notches. So the nerves that provides innervation to our lower limbs are much thicker than the ones in the upper limb. So that's why this infravertebral notch is much wider in the lumbar area than in the cervical area and than in the thoracic area in general. And then short transverse processes, short spinous processes that are almost horizontal and ends in a blunt end, not as pointed and not as angulated as the thoracic. And then we have superior and inferior articular processes, and then here we have connected of these two thoracic. Now for sacrum and coccyx. So sacrum, it's a single bone made out of 5 fused sacral vertebrae. This is the anterior view, this is the posterior view. The bodies are fused, and you can see here this transverse line. You don't have this cushion, this intervertebral disc, you don't need it because that's the end of the vertebrae. But instead of that, you have these transverse lines that you can see anteriorly. And laterally to these transverse lines, we have the sacroforamina, which continue posteriorly. We have sacral nerves anteriorly and posteriorly exiting from there. This collection of nerves are the sacral plexus. So it's a collection or network of sacral nerves. We also have a cervical plexus, we have a lumbar plexus, and a brachial plexus. We will see those in the nervous system chapter. So then the sacral plexus goes through the sacral foramina. And then the sacral plexus, it's a major collection of nerves that provides function to different organs in our body, like the pelvic organs, the genital organs, and as well provides innervation, sensation, and movement to our muscles of our thigh area, our legs, and also to our gluteal muscles. Okay, so then in the anterior view, what you can see, the base, the most anterior part, the most prominent part here, which is the sacral promontory, and then the transverse line, these are the bodies of the sacral vertebrae, anterior sacral foramina, this is the posterior sacral foramina, and then this will be the ala means wing, and then this is the apex, because it's like a triangle. A triangle has a base and a tip, which we call the apex. And then this is a coccygeal vertebrae. The first coccygeal vertebrae has lateral masses that are called cornu, in which some muscles insert and also some ligaments. And now in the posterior view, what you can see is the sacral canal just posterior to the promontory, which is this. It's an opening through which we have cerebrospinal fluid running. And then just below this opening for the sacral canal, we have the fused spinous processes, which is called the median sacral crest. And then you have on the sides of the median sacral crest, the posterior sacral foramina, and then you have the lateral sacral crest. So if the median sacral crest is the fusion of the spinous processes, then the lateral sacral crest will be the fusion of what processes? What are the name of the processes on the vertebrae that runs laterally like this? The transverse processes, right? So this is the fusion of the transverse processes, the lateral sacral crest, while this one is a fusion of the spinous processes. And now this canal, which is an opening, narrows down and it forms a hiatus that ends at the coccygeal area. And then here are the 3 to 5 fused coccygeal vertebrae that looks like a triangle. Questions about the vertebrae? Now for the ribs are 12 pairs. They have a shaft, which is this. They have a head that connects to the thoracic vertebrae. They have a neck below the head, which is this. And they have an angle and a tubercle next to the angle. And then we have 12 pairs. The first 7 vertebrae connects into the sternum, which is this bone, using their own cartilage, which is hyaline cartilage. Because they use their own cartilage to connect to the sternum, these vertebrae will be called true ribs or vertebrosternal, because they connect to the sternum. Now, the last ribs will be 8 through 12. They will be generically called false ribs. Now, pairs 8 through 10, they have a costal cartilage, but they piggyback into rib number 7. And these ribs are going to be called vertebrochondral ribs and are false. The last 2, which are 11 and 12, they don't have a costal cartilage. They are shorter than usual, so they don't connect at all to the sternum. So this will be called floating, false and floating. And now for the sternum, it has 3 major parts. The upper part, which is the manubrium, the middle part, that is the largest, which is the body, and the tip of the sternum, which faces inferiorly, which will be called the xiphoid process. The connection between the manubrium and the body is called the sternal angle. And the connection between the body and the xiphoid process will be the xiphi-sternal joint. Now, people under the age of 40 still hasn't ossified their xiphoid process. It's a hyaline cartilage. So that's another way to tell the age of a person. If they show you x-rays from a forensic scene and then you don't see ossified this xiphoid process, more than likely the person was less than 40. So here are the different parts of the ribs then. This is the head. It has articulation for superior and inferior vertebrae. This is the head. This is the neck. This is the tubercle. This is the articular facet for the transverse process. This is the articular facets for the body of the thoracic vertebrae. This is the angle. And then this is the costal groove where the vein, artery, nerve passes through. And this is the shaft. And this is the junction for the costal cartilage. First 7, true. Last will be false. And then 11 and 12 are floating. So that's all about the axial skeleton. Do you have any questions? Now for the appendicular skeleton. We have humerus in the arm. The head of the humerus articulates with the scapula at the glenohumeral joint in the glenal cavity of the scapula. And then the radius and the ulna are the forearm bones. The radius is lateral, the ulna is medial. And then both of them, radius and ulna, articulates with the carpal bones in the wrist. We have 8 carpal bones, 4 in the proximal row, 4 in the distal row. And then the carpals articulate with the metacarpals. We have 5 metacarpals. The metacarpals and the fingers, the phalanges in the fingers, are numbered 1 through 5 from lateral to medial. So we have metacarpal 1, 2, 3, 4, and 5. And then phalanges, we have 14. We have 3 on each fingers. Fingers 2 through 5. In finger 1, which is the thumb, we only have 2 phalanges. The phalanges are arranged into rows. The most proximal is called proximal row. The most distal is the distal row. And then in fingers 2 through 5, we have a middle row of phalanges. While in the thumb, we only have proximal and distal, which you can see here. This is proximal, this is distal. So then the upper limb bones connect the axial skeleton via the pectoral girdle with the appendicular skeleton. And functions of the appendicular skeleton, allowing, in the case of the upper limbs, allowing arm mobility and strength. And then also it forms point of attachment for muscles of the arm, forearm, the shoulder, and allow the passage of blood vessels and nerves. It protects them, these bones. So now let's talk about the pectoral girdle. So we have the collarbone that we know as collarbone, but it's known as clavicle for us from now on. The clavicle, it has an italic S shape if you see it from the superior view. It has a lateral border, which is ending at the acromial end. And it's called acromial end because it articulates with a part of the scapula that is known as acromion, which is this part. And then it has a medial border that ends in what we call an sternal end. Why is it called sternal end? Because it articulates with the sternum, with the manubrium. The manubrium has a little notch here that is called the jugular notch in this part. Okay? And then next to this lateral end, in the inferior view, you have a conoid tubercle. which allow for the insertion of ligaments. So this is then the clavicle. Lateral end with the acromial end, medial end with the sternal end. This is the body, and this is the conoid tubercle. Any questions about the clavicle? Scapula has a triangular shape with the broad body, which is this. It has a superior angle, inferior angle, lateral angle. This is the anterior view. In the anterior view, you have a fossa, which is called the subscapular fossa. Subscapular muscles insert into here. And then this is lateral border, this is medial border, this is the superior border. How do I know? Well, because in the lateral border above, you have this cavity that is called the glenoid cavity, which you can see here in this lateral view. This glenoid cavity fits the head of the humerus. And then you also have these processes, which is the coracoid process anteriorly and the acromion posteriorly. So this is lateral, where you have these processes. The medial border, you don't have processes. Now, in the lateral view, you can see the glenoid cavity, which is a shallow cavity. And then in the posterior part and the anterior parts, you have the coracoid process anteriorly and the acromion posteriorly. And this is the superior angle, this is the lateral border, this is the inferior angle. In the posterior part, you can see this broad projection that runs from the medial border of the scapula into the lateral border. So this is the spine. The spine ends in this broad projection, posterior projection, that is the acromion. The spine is easily felt in our back. So you just have to do this and then feel that projection, that bony projection is the spine. And this is the glenoid cavity, lateral border, medial border, inferior angle, superior angle, lateral angle. And it is not shown in here, but this notch in here is the suprascapular notch. Nerves, like suprascapular nerve, passes in here. And now above the spine, we have a fossa, which is called the supraspinous fossa. Supra, because it's above, spinous, because it's above the spine, and fossa, because it's a depression. And then below the spine, then we have the infraspinous fossa. Infra means below. And this is the location of the scapula. It's also known as wing blade. Questions? Humerus, the arm bone, here. Anterior view and posterior view. Proximal epiphysis, distal epiphysis. Proximal epiphysis, it has a round head, it has a neck, actually it has two necks, the anatomical neck below the head and the surgical neck in this area, close to the shaft. In the anterior view, you can see the greater tubercle, which is lateral, and the lesser tubercle, which is medial. And then in between the greater and the lesser tubercle, you have a groove, which is called intertubercular sulcus. And then in the lateral part, in the medial area, in the lateral part, in the middle of the shaft, you have the deltoid tuberosity, where the shoulder, broad shoulder muscle, the deltoid, fits into here. And then in the distal epiphysis, you have this trochlea, which is like a pulley. And then you have the capitulum, which is a round projection. And above the capitulum, you have a fossa, which is called the radial fossa. And above the trochlea, you have the coronoid fossa. The coronoid fossa fits the coronoid process like corona, like crown, of the ulna. And the radial fossa fits the head of the radius, which the head of the radius, it has a concavity that fits into this convexity of the capitulum to slide over, so allowing the flexion of the forearm over the arm. And lateral to the capitulum, we have the lateral epicondyle, and medial to the trochlea, we have the medial epicondyle. In the posterior view, you can see only the greater tubercle, the head, and then the radial groove that allows the running of the radial nerve. And then in the distal epiphysis above the trochlea, you have a broad fossa that is called the olecranon fossa. The olecranon process of the ulna fits into here. And lateral to this olecranon fossa is the lateral condyle, medial to this fossa is the medial epicondyle. That's the humerus. Any questions? For the radius and the ulna, so here is the radius, it's shorter than the ulna, and it is lateral, this is medial, so this is the anterior view, this is the posterior view. In the proximal part, the radius has the radial notch for the ulna, which is here, this is the head, and then here is the radial neck and the radial tuberosity. This is the neck, this is the tuberosity. And this connection between the radius and the ulna is the proximal radio-ulnar joint. And then here we have the chronic process, and then this is the trochlear notch, and this is the olecranon process of the ulna. And then we have a membrane that holds these two bones together, the radius and the ulna. This is called the interosseous membrane. And then here in the distal area, we have the distal radio-ulnar joint made by the ulnar notch of the radius and the head of the ulna. And this is the stylus process of the radius, this is the stylus process of the ulna, and this is the ulnar head, which you can see as well in the posterior view. And then here we have the head of the radius, and then this is the olecranon process of the ulna, coronary process here, the trochlea, and then you have this proximal radio-ulnar joint, while here you have the distal radio-ulnar joint. If you see laterally the ulnar head, the ulnar proximal portion, this is the trochlear notch. This fits into the trochlea of the humerus, so allowing us flexion and extension. And the olecranon process fits into here, the radial head fits into here, and the coronary process, which is this, fits into here, preventing overflexion. The olecranon process prevents overextension.